Good day, everyone. Welcome to the opening of a series of interviews with authors contributing their work to a new series in clinical liver disease known as Innovations in Hepatitis Elimination. And so we seek to help people around the world describe their activities to make the interventions available to key populations that will help us advance progress toward global hepatitis elimination. Since this is a launch of a new series for the journal, I'm really appreciative of having Nancy Rowe, who's the editor, join us today for a few opening comments. Nancy?
Thank you so much, John. I, as the editor, am incredibly excited about the innovation that this series has offered. CLD, or Clinical Liver Disease, is the AASLD multimedia journal. It is free, open access. It does offer CME for occasional episodes, and so please feel free. There is no membership to AASLD, although that's always encouraged, required. And we are so excited to host Dr. Ward's incredible, global elimination series to help work towards eliminating viral hepatitis in the world. Thank you, John, for allowing us to host this.
Oh, absolutely. No, it's a great partnership. I always enjoy working with Nancy and the whole group there, seriously, at CLD. And I think the way it works, if you feel like you have a body of information that would be helpful, please go to the website first and learn more about the author guidance from CLD. Go and learn more about the series. And then please contact us at the coalition to see how you put an article together. We're happy to help with that for people that don't have a lot of experience writing for the scientific literature. We don't want that to be an obstacle. We really want to help you get your information out. And then we'll forward that over to Nancy and her group for the full peer review process to get it into the journal. Thank you. So let's turn to our first journal publication. Pleased to introduce Dr. Katie Cassel from California to talk about her work to make hepatitis C testing and treatment available to indigenous communities in Northern California. I'm also joined by Dr. Nora Turow from the University of Southern California as our discussant today, as a Project ECHO that she created while she was at UCSF was very helpful in the implementation and the success of the project. So we'll be talking about the project in Northern California and then the role of Project ECHO for that project as well as others in the state. So Katie, welcome.
Thank you.
So turning to you, first off, the article just came out today. Just introduce yourself, tell us a little bit about yourself. I think it would be helpful for us to understand more about these 9 indigenous communities that you work with, and then just briefly describe some of the highlights of the project as it was described in the article that came out today.
Okay, will do. So my name's Katie Cassel. I'm a family medicine physician. I'm originally from Northern California and up in the Redding area, and then went off to Berkeley and then University of Pennsylvania, and then back to California for residency. And 19 years ago, out of residency, I joined United Indian Health Services, which is a tribally owned and operated organization in the far northern coast of California. It's been around for about 50 years. It serves 10,000 American Indian clients in the region, and the far northern coast of California has a very large 2-county service area that we have 7 clinics in, and the geographic region is about the size of Connecticut, so it's a pretty large area to get services out to. And the 9 tribes that we work for got together when the organization first began to give their federally granted dollars to pool those together to provide the best and most comprehensive services to the communities within the region.
That's great. So what really motivated you to put together a hepatitis C program? What was sort of what came to mind? What was revealed, in your practice there that really had you hit upon the development of this program?
Well, we knew for a long time that we had a lot of hepatitis C in our community, even before we had prevalence data. Just from people's experience with their individual practices, we knew that there were about as many people with hepatitis C as there were with diabetes in our particular community. And we also know just nationally that American Indian populations have a higher rate of hepatitis C. It's about 3 times the national average. And then they tend to have more complications from hepatitis C. So we knew it was a big issue. And then more recently, as we've started to get prevalence data for the county, Humboldt County has the highest rates of hepatitis C in California. So it's kind of a hot spot. And then, of course, medications were a little bit challenging for a number of years, but as the new medications came out, it became all of a sudden possible to treat a lot of people, and that created a lot of excitement. And then learning about the different projects within Indian Health to try to get more people treated, and then the opportunity with the hepatitis C echo through UCSF made it feel like it was safe and doable to get that started.
So what was the sort of, you have to put pieces together to get a program going, and some of it's getting sort of political approval from community leadership or from the health system, start getting the clinicians engaged and the laboratories even. So just wanted to get your thoughts about how you began to progress through getting those key stakeholders to the table.
Sure. Well, I think that actually our prevalence data really helps people understand how invested our community is in hepatitis C treatment. So as we've started to be able to collect data, the prevalence of in our adult population is about 6.5%, and among our baby boomers, it's about 12%. So almost everybody has a family member in our community that has hepatitis C. So when I presented, I started to treat a few patients after doing the Project ECHO, and then I presented to the board that we could really work on expanding this, treating a lot of people, really doing screening. And it really was nothing other than a little hesitation maybe about could the cost of the medications bankrupt the clinic. That was really the only hesitation. Otherwise they were like full on ahead, just make sure you understand how we're gonna pay for the medications.
Okay. Well, let's get Nora into the conversation here. See what was this like a push-pull that who chicken and eggs type of thing when this Project ECHO gets started, and there was outreach to Katie and her group, or did you hear about Project ECHO from UCSF and contacted them? I feel like a little bit of eHarmony here. We're trying to see what was what, and with E as elimination in this case. But just so how did this partnership come about through ECHO?
Well, I think that there was a little of both, actually. I think Katie nicely outlined that she, I think, identified that there was sort of need within her clinic, within that community. We simultaneously, as part of recognizing the importance of elimination, but more importantly, that we had a therapy that was becoming increasingly easy to administer, and where really treatment needs to be moved out of the specialist's office and into the primary care hands. We initiated Project ECHO. I have to say at UCSF, we were like late to the game because Project ECHO had been in place in many centers. In fact, Nancy, I think, was involved perhaps in the Chicago area with an ECHO as well. They had been in place during the interferon era, where it was really quite challenging and difficult to treat. I came on board when it was already easy, where we had all oral agents, and where really this ability to bring treatment to primary care, I think, was made even easier. And we were very motivated by really the numbers in California and the recognition that many of our patients that lived in Northern California would not come to San Francisco to get care. They couldn't. And so really being able to bring that care to them in the communities that they lived in was really important. And Katie was really among the first. We were very interested initially in Humboldt County. We also knew the numbers and understood that that was an area where there was both a lot of individuals with hepatitis C, but also a concentration of providers where we would potentially be able to reach in and establish contact. So I think that it was a little of, you know, us acknowledging that there was a good place to start there. That was one of the first counties that we really did outreach in, and that we really made efforts to bring providers on board in terms of Project ECHO.
Mm-hmm. So what were the type of providers that participated in ECHO, you know, as part of this project? You know, were they physicians only, or was it nurses included? And, you know, at its high point, you know, how many providers would participate in an ECHO session, and how often were those sessions held?
So we actually had a program, we called it ECHO Plus. And it was because we did the ECHO clinics, which were every other week. So twice a month that we would hold a 1-hour session. It's a very classic, you know, hub and spoke kind of virtual clinic. There'd be a short didactic followed by case presentations by the providers, which were, you know, a mechanism for case-based learning. But we also added to it what we called HCV 101, which was a sort of one-day immersion. And we actually went to communities that the hub team, which was the team from UCSF, for example, went to Reading and did an HCV 101 where we invited providers, and where anywhere from 30 to 40 providers would come for a day. And we found this to be very helpful to kind of get people sort of quickly on board with what's the scope of what hepatitis C is about and what does treatment look like. And to recognize that at the end of the day, they could go from being really uninformed about hepatitis C or have little information to being like ready to now start thinking about treatment. So we really utilized that tool as a kind of an entry point. Then we had our ECHO clinics every other week. And then we also put together a warm line where people could call or text the team kind of 24/7 if they had a question. And our approach was that we were trying to give them sort of a wraparound support, is what we called it, to say, we're here, you know, we're ready for you to be testing, we're ready for you to be treating. And sort of the composite was not just the ECHO clinics, but really this kind of idea that we're here and we're here to support you. The kinds of providers, we had a lot of primary care physicians. We had some infectious disease physicians that were kind of the specialists for the Northern California. And we had a lot of nurse practitioners and physician assistants. And for the HCV 101s, we'd sometimes get directors of clinics coming. So individuals that were not treaters per se, but were really important in helping the clinic to think about how are we going to implement testing? How are we going to think about, you know, the throughput of patients as we're thinking about treatment? So they were very valuable, even, you know, to also participate. But I would say that in the end, we probably had about half nurse practitioner, like APPs and MDs in our ECHO program. And at the end of the program, over the 4 years that we were really working hard in rural Northern California, we onboarded over 100 physicians in terms of bringing them into the ECHO family. In a given clinic, you know, anywhere from 15 to 30 providers would join us for a clinic.
That's amazing.
Yeah.
So Katie, let me get back to you. You know, how did you see, you know, ECHO, you know, as a key ingredient to getting providers engaged? And you can comment on that, of course, and then any other strategies that come to mind you think that were really helpful in getting providers engaged, I think would be interesting to people to know more about.
Yeah, so when ECHO first started, I was in a leadership role at the time, and so I really wanted to encourage providers to treat, so I just made sure lunch was available at the noon session. It's amazing how food is a motivator. And then as people had their own patients that they started to present, one of the things that I tried to do is to help people through the process, because I'd done a few cases already, so that they would have less hoops to jump through in terms of getting medications authorized or having templates set up so that it was easy for them to document the the treatment and the history of the patient. So the prior authorizations would go through. So it was kind of to grease the paths so that they didn't have as many hurdles to jump through for treatment. Echo in general, in terms of getting started, you know, there's a lot of anxiety whenever you're doing a new type of treatment, and being able to present those cases to the hepatologist and get feedback in a really, it was really a supportive environment, really took away a lot of the angst in treating those first few patients that weren't terribly complicated. And then as time went on, you know, we started to be able to treat more complicated patients, and even started to treat some decompensated cirrhotics with a fair amount of hand-holding from the folks at UCSF and a number of calls to the warm line. But it really allowed us to care for patients that were more advanced than I would have been comfortable treating before. And it felt like it was done in a safe way, which is really what we're looking for our patients. It's, you know, it can be hard to, when it's difficult for clients to travel to get the care that they feel, that you feel they might need from a specialist, but to be able to bring that inside in a way that's really, that really feels safe was important.
Yes, absolutely. Let me talk a little bit about testing. You know, you get the patient in front of you, you got to find who's infected, and always interested in what were your testing strategies. Did you use the baby boomer strategy when it came out? Did you go to, screening everyone? And did you do a community-based format for health fairs, et cetera, or strictly just rely on clinic visits? What was the approach there?
So we relied strictly on clinic visits, and the first universal screening that we did was in pregnant women, and we started that about 15 years ago. Once the baby boomer screening recommendation came out, we started to do that. And at first we did this screening, and it required a provider to put in the order and to remember that, oh yeah, this is a baby boomer and they haven't been screened. And then later we switched to having the prompt for hepatitis C screening come from within our electronic record. So we built a guideline, and if the patient hadn't had a hepatitis C test and they were in that age bracket, it would just put a prompt in that says this patient's due for hepatitis C screening, and then by protocol, the medical assistants could order that test. And we went from screening about 22% of our baby boomers up to 83% of our baby boomers. And then we expanded that to the adult population once that recommendation was in place. And over the last 4 years, we've screened a little over 70% of our adult population.
That's amazing. So just remind everyone on the call, or inform everyone on the call about how many people have you tested and found to be infected and have treated to this point, and then how many do you think are yet to be found? If you
yes. So I'll have to do a little math in my head. So we have about 6,000 adult patients, and we have not quite 400 cases with hepatitis C. Not all of those were active. And we've treated about 170 people, and we know we still have about 80 or 90 cases to treat. But we probably have 1,500 left to screen. So I imagine we'll find, a number, if somebody can do the math real quick, it maintains the 6% rate. We'll probably find another 60 or so cases.
I'm asking because, how do you maintain enthusiasm in the program? As you get toward an end of elimination program, you have to test more to find those few remaining people, and so some people begin to think that the problem's totally solved. And so I don't know how you continue to keep people, and keep this issue in front of them so that testing and treatment continues.
Mm-hmm. The guidelines are pretty rote in our system, so the medical assistants almost don't even think about what they have to order when it comes in. So that continues to happen. And then patients really are drivers. Most people, if they find out that they're infected for the first time, those folks seem to be the easiest ones to capture. Sometimes it's the clients who've had hepatitis C for 20 years and haven't had a problem from it yet, that they're like, why do I want to go through all this? But in general, the first time we detect people, especially in that first month, they're like, I just found out I have it and I want to get rid of it. So, so in some ways, the new diagnoses are a little bit easier than the ones who've been around a while. And I just like the numbers piece. So for me, that's really motivating, and seeing us get closer and closer to the elimination is exciting.
Mm-hmm. So do you cycle that information back to your staff?
Yeah, we do. At least once a year, we do a presentation to see where we're at and to encourage people to, test and remind people about how to do testing for people who have had a positive antibody in the past, things like that.
Have you seen many reinfections?
I have seen just one reinfection so far.
Okay,
So
so not an issue at the, at the moment.
Katie, can I ask you a question? I just want you to elaborate a little bit more on the transition in your testing, because I recall that your clinic took on universal screening long before it became kind of the recommendation, that you transitioned from targeted screening to screening everyone. And was that all driven by numbers, and was there a lot of effort on your part to sort of convince individuals that this was a better strategy for your clinic?
It was not really a hurdle to convince people when we started to look at the true prevalence of our baby boomers, and we're like, okay, this is so many times the national average, that it really makes sense to do screening for our whole population, because we just from demographics, we know that there's a cohort in the 20s, in their 20s, that we wanted to capture. So we pretty quickly just flipped it over, and it was really easy in our system to flip the guideline to be from an age group to just be everybody over this age. So it was simple.
Right.
Any aspects of the program that are strengthening other parts of the health system? I mean, sometimes, oftentimes, your elimination program, you're doing a good job approaching your primary goal of disease elimination, but along the way, it's improving like primary care to specialist relationships or laboratory, or using Project Echo for other disease states. Just interested in any kind of secondary gain from this type of project.
Yeah, definitely a benefit was that it got our providers involved with Echo for the first time. So as other Echo groups came along, providers had a sense of what that meant. And so providers did tap into other Echo groups for their kind of area of interest. And the project did strengthen some processes for how, when we're doing a project, how we integrate the different players, so like information management and putting structures into our electronic record so that it makes things easier. So when the screening moved off of the provider's plate and into the just a guidelines automated tool, it actually made it a lot easier to do, and we did a better job of it. So it allowed us to use tools within our system in a way that actually that didn't seem to add to the work, but still got us the results we were looking for.
And did you need to use any patient navigators or case managers to help people navigate the system, or is the system fairly well known to your patient population?
We definitely had to use a case manager. We thought when we first started that as soon as people heard we were treating hepatitis C, we would have a big rush, and we did for about 20 or 30 patients, and then there wasn't enough people that had been waiting, that we really had to do outreach. And so the nurse that I've worked with more closely, who's the second author on the publication, was really instrumental in doing the case management piece. So he would send letters and do phone calls, and he has a tickler file where everybody who isn't treated, every 3 months, he just touches base with them and says, let me know when you're ready to go through the process. And then eventually people will be at a spot where they're ready to do the treatment, and then they'll reach out to him, and as soon as somebody says they're ready, we just jump. So, so case management has been really huge, and it's becoming more important as we get to the clients who are harder to reach, which this last third of patients to treat, seems to need a lot more support than the first 2/3. So we're actually engaging, we have what's called outreach workers within our system. And so we're engaging with them to do more work out into the community and take a tablet with them so that we can do remote visits from the clinic, but not have them have to travel. So we're trying to get a little bit creative in our case management here towards the end.
No, that's great. That's really an important pearl. Thank you for sharing that. Nora, getting back to Project ECHO, so what's the future plans for, ECHO? Are you seeking to do any more engagement with other, American Indian communities or other communities in California now that you've moved from UCSF to USC?
Yes, I mean, the program at UCSF continues to thrive and I think is really well positioned to serve both North and Central California. But having moved now to Los Angeles, I've come to understand that even within an urban area, you can have really a lack of access or a lack of ability to get tested and treated just because you're dealing with 10 million people and they're in a big city and moving around the city, and especially now is quite difficult. So I'm very interested, and we've launched an ECHO here in Southern California. There's already an ECHO program at UCSD with Christian Raymer, and he's done a terrific job of working with FQHCs in the San Diego area. But we don't have that in Los Angeles and in sort of Southern California. So we've launched a USC ECHO to support development of treaters within the Los Angeles and Southern California area. And we've also have the Indian Health Services has reached out to us, and we're partnering with them to really help to really try to replicate what we have achieved in Northern California and Southern California in partnership with them to bring services, have more providers that are comfortable with treatment in some of the counties in Southern California. I think treatment has gotten easier actually as the years have gone by, and I'm a huge proponent that this is a primary care disease that can be easily managed, and we really need more individuals to be testing and treating and sort of replicate what Katie's done in her clinic. We'd like to see that happen in Southern California. So we've launched an HCV, we call it a certification program, but we're using very much the same model. We're doing an immersion, which is now just half a day, building on participation in the clinics and continued use of a warm line. So I think that model has worked very well in Northern California. So we're really introducing it to the South. But with this idea that we'll have a sort of a California-wide network that providers can tap into, I think Katie highlighted that, it's really about time. The primary care doctors, this is what I've learned, is they're super busy, and squeezing out time to be educated and become expert at HCV treatment requires they have to be sort of really wanting to do it. You're looking for those champions. And I think Katie's right. We try to do them at noon so people can use their lunch break, as it were. And she reminds me about the importance of lunch. But, I think that we're trying to make it fit into their schedules. But I think by having 3 ECHO programs in California, and all of us run our ECHO clinics on different days of the week and different days of the month, people can just tap into whatever one works for their schedule. And that, I think, would be the goal, is just to make, access to experts, the hub, available through a network of ECHOs that exist in California. So my goal is really just to have a California-wide network of treaters, but really, part of this elimination agenda.
That's great. Thank you. It's really great, Nora, that you're a liver specialist and you really get involved on the public health aspects to really do that outreach that really makes a lot of people get access that otherwise wouldn't. So really thank you for building that ECHO network beginning in Northern California, hopefully in Southern California hereafter. And Katie, thank you for taking this on and really helping your community truly remove hepatitis C and related liver disease as a cause of morbidity and premature mortality, and really showing a lot of essential components of an effective elimination program through political mobilization, training, specialist support through ECHO in this case, and then the data to track your progress and reinforce best practice as you move along. But you know, it also just is a reminder how oftentimes for hepatitis elimination, it's really that local champion, that somebody that really takes it on as a real passion and commitment, and that's certainly exhibited by you. And I just want to thank you for doing that, because that's what really makes this all so feasible and possible. So thank you very much. Thank for those people who asked questions via the Q&A line. If you have any more, just send them along over to the Coalition for Global Hepatitis Elimination, and we'll try to answer those after the call. I want to thank everyone for joining us today, and look forward to having another author conversation next month when we have another publication in the new Innovations in Hepatitis Elimination series. Thank you all for joining, and until next time, take care. Bye-bye.
Bye-bye.
Bye.